9-3.
Yeah. Okay.
Yes, sir. It's 9:03 p.m.
Okay. So, good evening, everyone.
Good
So,
evening, sir.
on behalf of NICE Hospital, today Dr. Ashok will be presenting two interesting cases of tracheo esophageal anomalies. Both cases have the same diagnosis but have different manifestations, different postoperative course, and different complications. So, in the meanwhile, when we are discussing the case course, we will be discussing the theory behind it. So, I hope everyone would enjoy this academic feast. Over to you, Dr. Ashok. Now you can start over.
Okay, sir. Thank you for your kind introduction. This is Dr. Ashok, DRNB Neonatology Resident, and my moderator is Dr. Vinay V. Kulkarni, sir, HOD of Neonatology, NICE Hospital. Today, I am going to discuss the seminar on the case series of Tracheo Esophageal Anomalies. This is a case of ex-male baby born at 40 weeks of gestation with a birth weight of 2.3 kg at outside hospital. Baby presented to our hospital at 8 hours of life with the signs of respiratory distress. Is a baby born to the primary gravida mother at 23 years of age. The baby is the product of ovulation induction, and except this, no other antenatal history was significant. Baby cried immediately after birth. After that, they shift. Upgars were not available at that time. Baby doesn't require any active resuscitation, but soon after birth, baby developed respiratory distress, for which baby was brought to NICE hospital at 8 hours of life. Baby required invasive ventilatory support within 2 hours of admission in view of worsening respiratory distress. At admission, we observed frothing of saliva from the mouth, and there was also difficulty in passing of NG tube was noted. We did chest X-ray on which coiling of NG tube was noted. Here you can appreciate the coiling of NG tube at T4 level of vertebra. This itself indicates the tracheoesophageal anomaly, upper GI, atresia of upper esophageal. And day 2, we stabilized the baby on SIME mode of support, and preoperative workup was done to rule out other associated anomalies. The common anomalies and the incidence of anomalies associated with the tracheoesophageal anomalies are cardiac, the incidence is 29%, gastrointestinal incidence 14%, genitourinary 14%, 10% each in musculoskeletal and Vactal syndrome, respiratory 6% incidence, and genetic 4%. Here in our case, on ultrasound abdomen, we found that baby had horseshoe-shaped kidney with normal medullary cortical differentiation, and RFTs were normal. And these are the common syndrome that associated with the tracheoesophageal anomalies: the Vactal syndrome, Charles syndrome, Chiasis, and Potter syndrome, Vactal H, 22q11 deletion, that is the Dijero syndrome, chromosomal 17q22q deletion, and trisomies conditions like 18, 21, 13, Fingerloid syndrome, that is similar to Vactal, and multiple gastrointestinal atricias. These are the common associations of tracheoesophageal anomalies. Preoperative requirements of the tracheoesophageal case, especially if we are planning to do surgery. Initial respiratory and hemodynamic stabilization is required before going for surgery. Preoperative upper GI contract study and microlaryngoscopy and bronchoscopy is required, especially in case of when we suspected multiple H type of fistulas. Preoperative, in our case, preoperative 2D echo ultrasound was done, and we ruled out other associated anomalies. On day of life 3, baby was operated through right thoracotomy. N2 side anastomosis was done in our case. Post-operatively, baby was continued on an invasive ventilatory support for 1 week, and baby was kept NPV for 1 week. The method of anastomosis, this is a case study. This is an article on which they studied the N2 method of anastomosis. So 38 cases were done end-to-end anastomosis, and 34 cases were done end-to-side anastomosis. But each method of anastomosis has own pros and cons. The entire decision is depending on the distance between the atretic segment of the esophagus, and the decision should be taken on table only. And in this article, in case of N2 side anastomosis, the esophageal stricture and tracheomalacia associated respiratory problems are more with N2 side, and anastomotic leakage trend was more towards the end-to-end anastomosis. But the total duration of NICU admission was less in end-to-end anastomosis compared to N2 side. And after 1 week of invasive ventilatory support, post-op, baby was extubated to NIPPV support. And before starting feed, we had planned to start feeds, and before plan to starting feeds, so we did upper GI contract study to rule out any other associated anomalies, any anastomotic leak. On upper GI contrast study, you can appreciate the clear-cut leakage of contrast dye into tracheobronchial tree. Here, this is the leakage. This is the picture of leakage, anastomotic leak into the right tracheobronchial tree. In this case, we continued baby NPO for 1 more week. Reason for that is slightest of the reflex can cause the anastomosis. Postoperative, these are the one of the most common postoperative complication. Others are anastomotic stricture, esophageal least motility, subglottic stenosis, vocal cord dysfunction, especially iatrogenic injury of vagus nerve, and bilateral recurrent laryngeal nerve. And tracheomalacia is also one of the cause. The incidence of these postoperative complications are overall mortality in tracheoesophageal anomaly cases is 5.4 to 7.5. The anastomotic leak is the overall most early common complication of postoperative, that is 6 to 8%. And long-term complication dysphagia is the most common, 75 to 100%. And GER also very common, 40 to 75%. Vocal cord injury and dysfunction, H-type esophageal fistula, 50%. In our case, the anastomotic leak, because usually anastomotic leak will seen when the gap between the atresia is more than 3 centimeters, then the chance of anastomotic leak is more. But the baby usually present from day 3 onwards with signs of right upper lobe, continued upper lung collapse, and unexplained right pneumothorax and pneumomediastinum. Saliva or gastric contents may drain more into the chest tube. This is the indication of the anastomotic leak. In our case, we followed conservative management for this leak. Why? Because this is very small leak and no signs of pleurisy or sepsis present, and the baby also stable on minimal respiratory support, and we detected it in early. That's why we just followed conservative management by keeping the baby NPO for 1 more week. After 1 week, again we repeated the upper GI contrast study. Here you can clearly make out that there is no anastomotic leak. That's why we started feed and reached full feed within 3 days. Simultaneously, we win the baby to room air by day 20.
ब्रो, ये तुमने कुछ ढीला किया है क्या? ये इतना पीछे भाग रहा है, कुछ ढीला किया है क्या?
On day of life 21, there was difficulty in passage of positive was noted. We suspected stricture. The common cause here you can appreciate the stricture. After this NG2 we couldn't able to pass. The common reason for strictures are scarring, chronic GR inflammation, ischemia at anastomotic site, physical technique.
Dr. Ashok, why don't you mute all the participants?
Yes, sir. Yes, sir. We'll say this someday. Yeah, in our case, we followed conservative management. The management protocol for esophageal stricture and dilatation, endoscopic structuroplasty, surgical revision, and laser therapy. Usually, endoscopic structuroplasty is difficult by using rigid endoscopy, but it is usually difficult especially in case of N2 side anastomosis, as there is a more chance of anastomotic rupture will be there, and it is usually done after 6 to 8 weeks of post surgery. That's why we didn't this endoscopic dilatation, and surgical revision also not the first better option for this kind of structure. Laser therapy is just not a high proven studies was there. That's why we just followed the conservative management by using the 10 French NG tube. After that, on day of life 23rd, baby developed some respiratory distress in the form of suprasternal subcostal retraction along with persistent biphasic stridor. Here you can appreciate the subcostal retraction along with suprasternal. And the baby again, we started double CPAP support for this respiratory distress. At this point, our differentials were aspirational laryngitis, subglottic stenosis, and mediastinitis. We did chest X-ray, that came normal, but Strider gradually increased over despite of our treatment. Strider was gradually increasing over next 3 days. ENT evaluation done. It showed that the clear-cut subglottic stenosis, you can make out the narrowing of the subglottic area on microlaryngoscopy and bronchoscopy view. On the same sitting, laser ablation and balloon dilatation of the subglottic stenosis was done. This is how the laser ablation. This is how the laser ablation of the stenosis and followed by balloon dilatation of the stenosis segment. Yeah, this is how the subglottic area will looking like after the surgery. After that, further exploration, only there was a Tracheo Esophageal Fistula pouch was found at carina level, except that no other anomalies were found. This is the Tracheo Esophageal pouch at carina level. That is the fistula of the esophagus. Subglottic subglottis is the very narrowest part of the neonatal larynx. It is composed of a cricoid cartilage and with cricoid cartilage with a fixed ring. It will cause the increased work of breathing and biphasic stridor, as we saw in our case. Although it is more commonly acquired, it can be congenital. This is the Carton-Meyer classification of subglottic stenosis. In our case, baby had grade 3 type of subglottic stenosis. This is how it looks like. And 71% to 99% of stenosis will be there in grade 3. On day of life, 30, baby tolerated the surgery well and able to make the baby to room air within 24 hours of surgery. And discharged baby on room air with OG fits for esophageal stricture. So we continued OG fits and discharged the baby on that. We advised endoscopic dilatation after 6 weeks. This is the first case, and coming to the second interesting case, this is the baby of Y, male born at 39 plus 5 weeks of gestational age with a birth weight of 2.3 kg at outside hospital. This case also delivered at outside hospital. Baby is born to primary gravida mother through spontaneous conception. Mother had history of, she is the known case of hypothyroidism and on thyroid supplementation, except that no other significant history was found. And the baby cried immediately after birth and doesn't require any active resuscitation. After routine newborn came, baby was shifted to mother side. After giving initial beats, after giving initial beats, the baby developed vomiting with respiratory distress. That's why they admitted the baby in NSU and started giving CPAP support and continued NPV on first day. After that, they started giving OG fits and continued for 3 to 5 days. On day 6, they again restarted the giving trial of parallel fits, on which baby developed.
I think Dr. Sorry, Dr. Ashok, one second. Dr. Riddhi Singh has to mute her audio. Dr. Riddhi Singh has to mute her audio.
So there is an option at the admin
Yes,
side to mute each one of them, all the participants. Why don't you do it off?
Yes, sir.
Ashok.
Yes, sir. Yes, sir. I am doing.
रवीना खातून वाली पूछ रही है दूध पचा रहा है वो दूध देती है लोग क्या बने सब दे रहे हैं यही ना
Postnatally, after giving feed, baby developed vomiting and respiratory distress. Again, after starting parallel feed on day 6 of life, baby developed respiratory distress. Symptoms appeared same like previous, like vomiting, choking, like episode. Baby was referred to NICE hospital on day 7 of life. On OP ER itself, we given trial of parallel feed on which baby developed vomiting choking and coughing. Here you can, in this video, you can clearly appreciate the vomiting and coughing also. Yeah. At this point of our differentials in our mind was cleft palate, laryngeal clefts, esophageal webs, external esophageal compression, CNS causes, and tracheoesophageal anomalies. We ruled out the cleft palate by examination. Esophageal webs and external esophageal compression was ruled out as there is no stridor. And baby also doesn't had any signs of encephalopathy. That's why CNS causes also ruled out. That most striking and possibility at that point of time is tracheoesophageal anomalies, as the baby had cough, cyanosis, and choking immediately post feeding. And our working diagnosis at the time was suspected tracheoesophageal fistula with aspiration pneumonitis. We started NIPV support for respiratory distress. Chest X-ray was done. That was suggestive of aspiration pneumonia. Started giving antibiotics after sending blood culture and septic screen. After stabilizing the baby on day 10, we did upper GI contrast study to know the level of fistulas or anomalies. This is the upper GI contrast study. You can clearly appreciate how the contrast dye entering into the tracheobronchial tree on both sides. So here the connection this is a proximal connection of tracheoesophageal fistula. This is a picture of the H-type fistula. And baby was operated on day 12 of life through transcervical approach and continued NPO for 7 days and on invasive ventilatory support. On day 7, baby was extubated and weaned to NIV, but within 12 hours of extubation, baby required again reintubation because of upper GI bleed and worsening respiratory distress. Our possible extubation failures were upper airway obstruction, anastomotic leak, mediastinitis, and sepsis. Sepsis workup was done. It came positive, and deranged coagulopathy was there. We treated for that, and no signs of meningitis. Meningitis was ruled out. IV antibiotics were given for 10 days and stopped. Baby was made room air on day 30. Feeding nutrition wise, we started giving feed from 18 day, that is post of day 8 onwards, and reach full feeds by day 21. We given trial of oral feeds on day 34, and on which baby doesn't have any signs of dysphagia. That's why we discharge the baby. Currently, baby is doing well, 8 months, 7 kg, growing well, on high risk follow-up. 6 months neurological examination also normal. Tracheoesophageal fistula is the some discussion part. Is tracheoesophageal fistula is the most common congenital anomalies of the esophagus, and the prevalence is 1.7 for 10,000 live births. Of this, more than 90% will have the tracheoesophageal fistula. 50% non-syndromic without any 50% non-syndromic without any other anomalies. Embryologically, respiratory system and esophagus will develop from the foregut, and upper part of esophagus develop from the retropharyngeal segment. Lower part is from the pre-gastric segment of the primitive gut. At 4 weeks of gestation, there is the laryngotracheal groove will be formed that will separate and one longitudinal furrow develop that will separate the respiratory primordium from the esophagus. If any deviation and alteration in this embryological pathway, it will lead to tracheoesophageal anomalies. These are the liver lung buds, and a clear-cut demarcation between the esophagus and lung buds. If there is any deviation in the formation, baby will present with this kind of fistulas and atresia. This is atresia of the esophagus and a fistula. C type. This is the H type. These are the types of tracheoesophageal anomalies. Type A, isolated esophageal atresia with blind both upper and lower esophageal segment. Type B, atresia with proximal fistula. Type C, atresia with distal fistula. In type D, both double fistula. In type 4, this is H type. And type C and type C were what we discussed earlier. even though this is rare, but it can be present at a neonatal period. Antenatal diagnosis, we can diagnose antenatally by the absence of stomach bubble and may present with polyhydramnios single umbilical artery. We can diagnose as early as 20 weeks of gestation by fetal MRI, but the predictive value of antenatal diagnosis is 55%. Postnatally, if the baby doesn't fade, the baby looks, most of the time baby looks like healthy. If there is no associated comorbidities or anomalies. More commonly, baby, in case of upper esophageal atresia, baby will vomit the initial feeds. That itself indicates the atresia of the esophagus. And continuous frothing will be observed from the mouth in case of upper esophageal atresia. In case of H-type fistulas or double fistulas, we can find out coughing, sinuses, and respiratory distress symptoms. And if we're not able to pass the NG to beyond the 10 to 12 centimeters, 10 to 12 centimeters, that itself indicates the upper esophageal atresia of the upper esophagus. And successful passage of esophagus doesn't rule out the H type of fistula, even though it's rule out the upper esophageal atresia. Aspiration of gastric contents via distal fistula will cause the more damaging pneumonitis than from the blind upper porch. Clinical presentation wise, these presents the atricial type A and C will present with excessive drooling of saliva from the mouth, and aspiration of saliva or milk can lead to aspiration pneumonitis. And in case of type C TEF, the lungs may be exposed to gastric secretion because of distal fistula in type C. Type A fistula, it is difficult to detect because of anatomical features. In the neonatal period, it is rare to diagnose because of low morbidity and high misdiagnosis level, but they present in infancy in the form of recurrent pneumonias and bronchospasms. Birth weight of more than 2.5 kg, baby not fed before diagnosis, no pneumonia and no other anomalies, and gap between the atrial segment less than 2 cm, and the surgeon is able to do good anastomosis without tension are the good prognostic factors. Despite of this, associated anomalies, especially cardiac, presence of pneumonia and need of ventilator requires also matters in the prognostication of the surgery and the prognostication of the cases. This is the Watterson classification of the surgical timing of the tracheoesophageal anomalies. If the weight of the baby is more than 2.5 kg, directly can take the baby first to surgery. If the weight of the baby is in between 1.8 to 2.5 or any pneumonia or congenital anomaly, short-term delay is required to immediate stabilization. After stabilization of the baby, surgery should be taken, and babies require stabilization initially. In case of if the baby's weight is less than 1 kg or severe pneumonia or congenital anomaly, these babies require stage repair. This is the Spitz classification that will tell the survival percentage of the tracheoesophageal anomalies. If the birth weight of the baby more than 1500 grams with no major cardiac anomaly, survival rate is 98.5%. If the birth weight of the baby is less than 1.5 kg or major cardiac anomaly is there, then the survival rate is 82%. If the birth weight is less than 1500 grams and major cardiac anomaly is there, then survival rate will come down to 15%. Pre-repair bronchoscopy is although many centers doesn't follow this pre-repair bronchoscopy, but this is useful to detect the proximal H type of fistula, and it will give the clear-cut location of the fistula, and it will determine the unusual character of the fistula, like double fistulas and trifurcation. And it determines the presence of tracheobronchitis. It will locate the aortic arch, influence the anesthetic management also. This is the interesting case on which a 2 kg 35-weeker female was initially diagnosed as a tracheoesophageal type C fistula. They operated successfully that fistula, but ventilatory wise they remained challenging for them. Intraoperatively, they did flexible bronchoscopy. They find out H type of fistula. That's why initial pre-bronchoscopy is very important in case of this proximal H type of fistulas. And the same sitting, they did bronchoscopy with repair of H type fistulas along with the type C Tracheo Esophageal Anamolies. This is the bronchoscopic view, and this is the thoracoscopic surgery and surgery of the H-type fistula. Management wise, conventionally open surgery, thoracotomy surgery is followed in many centers. This is the cervical approach will be followed, especially if the fistula is above the second thoracic vertebral level. If it is more caudal, then thoracic approach is required. Thoracoscopic approach has certain advantage over the conventional thoracotomy. It will give the great visibility of the field. It will lower post-operative pain. It will improve the aesthetic outcomes, and it is also a very minimally invasive technique. And recent advances are laparoscopic repair of the tracheoesophageal anomalies. If the gap between the atretic segment is more than 3 to 4 centimeters, that is more than 3 vertebral body, then the baby requires stage support and stage repaired, and the neoesophagus is also created by using gastric, jejunal, or colonic segments. These are some newer endoscopic techniques. This endoscopic closure of recurrent tracheoesophageal fistulas are useful by using methods like ag laser, diathermy, histoacral cement, and fibrin sealant. But overall success rate in the fistula closure is 80%. Endoscopic repair is usually useful in the recurrent tracheoesophageal fistulas. It will prevent the frequent surgical repair. It will be useful by using the endoscopic closure. But the baby requires 2 to 6 endoscopic procedure. Here, this is the tracheoesophageal fistula. Initially, they cannulated the fistula. After that, they injected acryl glue into that fistula. After that, they cauterized the fistula by using 4 French bulb diathermic electrode. After 3 months of repair, how it looks like, the clear cut complete, it is looking like very nicely after 3 months of post surgery. And also this is the esophagoscopy, and you can appreciate the tracheoesophageal fistula here. In this endoscopic treatment, recurrent tracheoesophageal fistula with a combination of histoacral and lipodial, after surgery, how it looks like. The modalities of endoscopic treatment are injection of tissue adhesive. It will give 67% success rate. De-epithelialization of mucosa, it has 14% success rate. A combination of both de-epithelialization and tissue adhesives will have 39% success rates. And endoscopic ablation of recurrent tracheoesophageal fistula initially by using histoacral gel, and after that they will inject the fibrin gel into the fistula. This is the tracheoesophageal fistula, and which they inject the fibrin glue gel. This is the biological product that will give effective. It is very effective in first attempt only. It will demonstrate proper epithelialization. To summarize, our first case is the classic type C tracheoesophageal fistula that presented at birth, operated through transthoracic approach. N2 side anastomosis was done. Anastomotic leak was there, but we followed conservative method for that. Baby had associated arthro kidney and subglottic stenosis. Esophageal stricture was present in that case. Progressive dilation was advised. In other case, that is a rare H-type fistula, even rare to present in newborns, but it manifested late, was not detected at birth because of proximal H-type. We follow transcervical approach, and there is no residual morbidity was observed in this case. Take-home message is tracheoesophageal fistula can have varied phenotypes, that is ranging from early infancy to even childhood, and high index of suspicion should be required and proper history and physical examination will guide good prognosis. There are numerous post-op complications, and timely diagnosis and appropriate management is required to treat these complications properly. Subglottic stenosis can be the congenital association, as we saw in our case. H-type fistulas with proximal configuration can present even at early neonatal life. If present at infancy, they will present as pneumonias and bronchospasms. Anastomotic site leak is one of the most common complications. Thank you.
Thank you, Dr. Ashok, for your
Thank you,
crisp
sir.
and lucid presentation.
Thank
I
you, sir.
think a word to add is that in India, we see a lot of tracheoesophageal fistulas, especially in our public sector hospitals. They do get operated, but many of them do not make it. So, unfortunately, what we have is lack of data from our country. Though we have abundance of cases, the lack of published literature is seen from our country, especially in the public sector hospitals. So I think residents can take up these as follow-up projects and do publish whatever is their unit experience or hospital experience, so that we get more insights into this very common anomaly. Second important point I would like to make is now the recent advances and the recommendations for doing a pre-repair bronchoscopy. Means before subjecting a tracheoesophageal fistula baby to surgery, a bronchoscopy would guide the surgeon as well as attend any other associated anomalies and complications. So pre-repair bronchoscopy should become a norm in coming future. So as more data emerges, I think we can consider it, especially in those centers where we have the equipments available.
Yes.
Any questions we would like to take up? Dr. Kirti is asking depth of insertion of the endotracheal tube in a TEF case. You mean to say before surgery, the depth of endotracheal tube insertion. If the fistula is very high end, that is, in between T2 to T4, preferably you go beyond that so that you can suction out the gastric secretions from which are pouring from the salivary secretions which are pouring out into the trachea from the fistula. But if the fistula is from the gastric end and the esophageal atresia is there, the depth of insertion will not make much difference. You have to suction out all the gastric contents continuously. In such cases, bronchoscopy would do a better output than the only intubation alone, if you want to drain the secretions coming into the carina. One more question. Yeah. Thank you all for attending this academic session, and I thank Dr. Ashok for this wonderful and elaborate presentation to give insights into the variety of presentations of the tracheoesophageal anomalies. So any follow-up doubts can also be posted to our hospital email ID or into the IAN group. We will be happy to address them. Thank you
sir.
very much.
Thank you, sir. Thank you for your support.
So we shall all leave the meeting then.
Yes.